would like to thank you all for giving me this opportunity to present a case that is actually a nightmare for me till now. But that's why we're bringing these cases to share and learn our experience and our complications, and we learn from our mistakes. Okay, so I have this gentleman who's a 46 years old. He's a very active guy. He has typical chest pain, typical angina for the last few weeks. His only risk factors is heavy smoker and premature history of coronary artery disease in the family. He's very active, despite he's active smoker and heavy smoker. He smokes a packet a day. He still can run 5 times a week. So he's a very active guy. He has no other comorbidities. All ECGs and blood works, including echocardiogram, was normal. So I didn't stress him. I was so convinced that this is true angina, and he's a very active guy, so I brought him for the cath lab just to make sure maybe I'm wrong taking the history. This is the right coronary artery. It showed just the TIMI flow is almost 2.5, but is a slow flow, but there is no active lesion. This is his left coronary artery. There is nothing in the left main. There is nothing in the circle or OM significantly. Then this is the cranial view. Okay, so you can see there is mid-LAD disease and probably diffuse distal LAD. Here at that time, I gave a lot of nitro, just maybe it's going to improve. I thought there is maybe muscle bridge, so I was trying to avoid stenting. So this is my initial impression. Everyone around me, this is an active guy, don't leave it. Here is the steno-ocular reflux. So I said, okay, let's FFR it. Unfortunately, in that lab, we have 2 cath labs in the hospital. Unfortunately, in that cath lab on that day, there was no FFR. So I didn't FFR it. That's the second thing. I'm just pointing how complications could happen. Third, I said, okay, I'm going to OCT just to prove it. When I'm bringing the OCT catheter, the nurse, actually, the OCT catheter fell down. So I said, okay, that's everything. All the signs point me towards stenting. Okay, I should fix it. And then I went back, oh, this is a 46 years old who's active. This is a mid-LAD. I'm going to use the PVS. Hey, I'm going to use the first PVS in Saudi Arabia. I use it partially during my fellowship, but I'm going to use it here. The third thing is I was not sure how many BVS stents are around. So I started a balloon, and then you can notice that there is some dissection, and as according to Dr. Colombo, that's what I need to see, dissections to make sure that I prepare the lesion. I went with a 225 NC balloon with a high pressure, and that's what I get. So initially I want to stent from here, crossing that diagonal. This is my initial plans. And then I said, okay, bring me the 2.5 PVS. And I thought I'm going to take 33 or 38 based on this measurement. They said, no, we have only 2.5, 28. I said, I hope I can cover the lesion. And then unfortunately, I will not show these pictures. I didn't cover the lesion properly. So I have to use the next stent. So I go give me 3.0 short PVS, and I will do overlap. The only stent available as a 3.0, which is the last PVS stents. Unfortunately, my partner finished all the PVS stents that we have, was 3.028. So I said, okay, I'm going to do overlap here. I did too much overlap, and you can see. And this is the picture after I deployed the 2 stents. You can see in the distal stent here. I don't know what happened but before I deployed it, it was not like this. So is the stent collapse? Is there a dissection? Is there any thrombus? So I decided to balloon. I did multiple balloon, and then I got this result. For me, it was acceptable, not the ideal, not the results that I wanted, but I OCT it. Here is the distal lesion. The stents will oppose, but there are a lot of stuff inside. This is at the distal part. This is in the middle part. Still there is some disease, and the proximal part of the stent. I didn't notice any dissection in the middle or the distal part where the dye hung out. So I said, okay, I have to stop here. Please, I just convinced myself to stop and to put the patients, because I wasn't sure there is a lot of distal probably clots in the stents. I will put the patients on GP2B3 inhibitors, aspirin, Plavix, heparinize him very well, send him up in the CCU. I put him in 48 hours. He was fine, no ECG changes, completely mobilized without any chest pain. I was happy. I didn't recath him. But this is not the end of the story. So 10 days later, only 10 days, he came with a typical chest pain. Now he had very non-specific ECG changes, but not normal. But he had a troponin of 8. He was admitted into the CCU. I was not on call on that night. He was fine. I mean, he was hemodynamically stable. There is no STEMI, so we didn't call the cath lab on that night. But I was lucky that I was the cathing doctor in the next day, so I cath him. And guess what? There's no LED anymore. So I start to shoot myself in the head. Okay, what I did. So I did multiple balloon dilatations, no flow. I even passed export catheter just to suck some clots. I sucked some clots, said there is still no flow. So I take a 3 ONC balloon and I dilate. This is just the proximal dilation. And here. So here's the part that I shot myself in the head. I want to kill myself. A guy that I avoided, initially that I want to avoid stenting him. I put a PVS, I did too much overlap, end up with thrombus. I want to avoid putting a metal stent in there, a metal jacket in the middle LED. Now I have to put a covered stent. I tried multiple times with balloon tamponade. Oh, trust me, I tried multiple times. Balloon tamponade, and it's nothing. I consult my colleague. Yeah, we have no options. This is class 3 perforation. Put it. I know it's intracavitary. But at that time, I took the decision with my colleague just to put the covered stents, and the results will be bad. This is the final results. Not the best results at all. You diffuse disease after the stents, maybe a little bit oversized here. There is maybe now disease proximal to the stent. You can see the marker here, and you see the dye hanging here. I put the patients on GP2B3 inhibitors for 5 days, kept him in the CCU. I did a modified Bruce before sending him home. And you can see here, I lost a big diagonal. So now I have a patient that's 46 years old. I pretty much destroyed his LED. I should have said that. With the use of PVS and then covered stents, the risk of in-stent restenosis will be higher than that. I don't know if he's going to keep his LED. He was fine for a while, and then he was admitted to another hospital for a chest pain. And just to let you know that he had similar findings, because I get the angiogram from my colleague, but they were not happy about leaving this area, so they put a drug-eluting stent just in this area, avoiding the overlap to the PVS. So what went wrong? I think the first thing that went wrong is I didn't go with my gut not to do anything. Leave the patients alone, avoiding the stenocular reflex. Then I should have done FFR to prove this lesion, or at least OCT prior, which is now I'm doing before using any PVS, OCT or IVUS prior, and then PVS, and then OCT or IVUS. To be honest, I didn't try medical therapy before. That's a number 2. Using the PVS, overlap, not a proper size, not using proximal to distal, I used distal to proximal. And then this, I thought to stent that proximal lesion before I sent the patients home, but I said that's enough. He has TIM3 flow. Should I recath him? Should I cross that diagonal? Because on the lateral wall there is now akinesia in the lateral wall. Where's the diagonal that's lost? Lots of things happen, but I learned a lot from this case. I want to share this case, and I'm really happy to hear any comments or any questions.